All right, I think we're going to go ahead and get started. Hi, everyone. Welcome to today's webcast, HL7 interfaces and what they mean for meaningful use. My name is Carolina Velasquez. I will be presenting with my coworker, Phil Anderson. We both have experience working with interface engines that transform HL7 messages. I work with the Orion Rhapsody interface engine. I also have experience with ConnectR, which is Allscripts' proprietary interface engine. Phil has developed multiple HL7 interfaces that have been met specifically for meaningful use purposes, and I've worked with HIEs and hospitals to develop all kinds of HL7 interfaces. Just as a little side note, this webcast was requested for us in 2014, so this is to go over HL7 and how it relates to meaningful use. One thing to note, your microphones are muted. We will, if at any point throughout the webcast you have a question, in the WebEx application, you can pose a question and we'll try and get to them at the end of our presentation. So we'll go ahead and get started. This is a brief overview of what we'll be covering in our webcast, exactly what is meaningful use. We'll talk about eligible professionals versus critical access hospitals. I'll touch a little bit upon incentive payouts, the meaningful use timelines, differences between meaningful use stage 1 and 2, MU2 objectives, clinical quality measures, and then Phil will take over and talk more about HL7. He'll go in depth about HL7 to meaningful use 2 measures. He'll give us a brief demonstration, conclusion, and then we'll touch on any of the questions that you all might have. So what exactly is meaningful use? According to healthit.gov, meaningful use is using certified electronic health record technology to improve quality, safety, efficiency, and reduce health disparities. It's also used to engage patients and family, improve care coordination and population and public health. It also helps to maintain privacy and security for patient health information. Ultimately, it's hoped that the meaningful use compliances will result in better clinical outcomes, improved population health outcomes, more transparency and efficiency, also giving the ability to empower those patients to view their charts, and then also the ability to do more research on clinical data and health systems. Meaningful use sets specific objectives that eligible professionals, CPs, and hospitals must achieve to qualify for Centers for Medicare and Medicaid Services incentive programs. There are actually 2 EHR incentive programs. CMS oversees the Medicare EHR incentive program, and the state Medicaid agencies manage the Medicaid EHR incentive program. In order to meet meaningful use, CMS requires that all the products being used for attestation meet 100% of the CMS required criteria. And so we'll talk a little bit more about OMC certified EHRs, but essentially all of the applications that you use to meet attestation must be certified, and all of them combined should meet 100% of the CMS required criteria. So what exactly is an eligible professional or a critical access hospital or an eligible hospital? An eligible professional under the Medicare EHR incentive program includes doctors of medicine, doctors of dental surgery or dental medicine, doctors of podiatry, doctor of optometry, and chiropractic. Hospital-based eligible professionals are not eligible for incentive payments, and CMS defines a hospital-based eligible professional as someone who 90% or more of his or her services are performed in a hospital inpatient setting. So eligible professionals can choose to attest for either Medicare or Medicaid meaningful use. For attestation for eligible professionals, it's during the calendar year, so from January to December. And then for hospitals, the definition of a hospital for CMS in order for attestation for the Medicare EHR incentive program is subsection D hospitals in the 50 states or DC that are paid under the inpatient prospective payment system. It also includes critical access hospitals and Medicare Advantage affiliated hospitals. And then an eligible hospital under the Medicaid EHR incentive program is acute care hospitals, which include critical access hospitals and cancer hospitals with at least 10% Medicaid patient volume. And then for hospitals, they can choose to either attest for Medicare and or Medicaid if they meet the certain criteria. And for hospitals, the attestation period is during the fiscal year. We'll go ahead and we have some tools set up for you guys. Fallon, if you could please send out poll number 1.
Sure. For this first poll, sort of piggybacking on that side, we're interested in who we have in our audience. So if you're representing part of an eligible hospital or eligible professional. So if you wouldn't mind taking, I'll leave this open for probably about 30 seconds. So if everyone wouldn't mind taking a few seconds and answering the question. It looks like right now we have sort of a mix between eligible hospital and eligible professionals, but we have a few people on this call that are neither. So I will keep this open for a few minutes, but I'll pass it back to you, Carolina.
All right, thanks, Fallon. Here are the incentive payouts for Medicare versus Medicaid. More specifically for EPs, the matrix for hospitals gets a little more complicated due to the number of EPs that may be working under them. So as you can see, for the first one, it's Medicare. If you start attestation now, you're no longer eligible for incentive payouts through the Medicare program. As you can see, 2014 was the last year to receive incentive payouts of $24,000. But just because you don't receive incentive payouts doesn't mean that you're home free. You actually, in order to not receive the penalties that come with not meeting meaningful use, you still have to show meaningful use of your EHR system. Otherwise, there is a fiscal adjustment of 1% of all Medicare physician fees scheduled. So 1%, and it'll increase the percent up until 2017, where the max is, I think, 5%, and it'll continue at 5% until providers show that they are meaningfully using their EHR product. Then on the second one, we have Medicaid. Medicaid, you can still receive incentive payouts. The payments do not decrease over time. There's more of a push to try and get people to prove meaningful use with Medicaid certified EHR products. So here we can see the meaningful use timeline. So if you take a look, if you start attesting this year, you'll have to attest for meaningful use stage 1 in 2015, meaningful use stage 1 in 2016, and then meaningful use stage 2 for 2017 and 2018. There was a little bit of a adjustment on 2014 due to the fact that EMRs, there was certain EMRs that hadn't gotten around to the process of being certified for the 2014 certification process. So CMS decided to adjust the attestation period to allow hospitals to attest for meaningful use stage 1 still in 2014, or meaningful use, or start at the end of 2014 to attest for meaningful use stage 2. So meaningful use stage 1, it contains core measures, menu measures, and clinical quality measures. I'll explain further what those are and how those are different, but for an eligible professional, you must meet 13 required core objectives, 5 menu objectives from a list of 9, which is a total of 18 objectives, and then a total of 9 clinical quality measures for eligible professionals. For eligible hospitals, you must meet 11 required core objectives for meaningful use stage 1, 5 menu objectives from a list of 10, which is a total of 16 objectives. And then for the 2013 list of clinical quality measures, eligible hospitals must meet 15 of them. And then for 2014, at least 16. Most organizations have already completed this step, and it was mostly due to the incentive payout. If you're starting attestation now, you'll have to start with this stage. So meaningful use stage 2, there was new measures that were added. There were more refined criteria and higher thresholds. Some measures were combined into one, and the measures, again, are different for eligible professionals and hospitals. So the number of menu measures for professionals went up from 13 to 17, and then there was less menu objectives to achieve and less to choose from. There's 3 out of 6 instead of 5 out of 9, a total of 20 objectives, and then eligible hospitals must meet 16 core objectives, 3 menu objectives out of 6, totaling 19 objectives. So, for example, a higher threshold for meaningful use stage 1, 50% of all patient demographics for eligible professionals need to be recorded in the EMR. For meaningful use 2, there was a threshold of 80%. So here, I know this is a lot, but this is the meaningful use 2 core objectives for eligible professionals. As you can see, there's 17 of them. All of this can be found on the CMS website. And here, to highlight on our topic of our presentation, are the ones that can be met using HL7 or interfaces. Here we have a list of the menu objectives for eligible professionals. Again, an eligible professional would have to attest for 3 out of these 6. As you can see, 4 out of the 6 can be or absolutely need to be met using HL7 interfaces. And then the clinical quality measures, they're also referred to as CQMs. They're tools that help measure the quality of healthcare services provided by eligible professionals and eligible hospitals within our healthcare system. These measures use data associated with the provider's ability to deliver high-quality care or relate to long-term goals for quality healthcare. Eligible professionals who demonstrate 2014 clinical quality measures need to report for 9, like I said before, and eligible hospitals need to report for 16. CQMs may be able to be reported electronically or via attestation. Now, there's a requirement for the National Quality Strategy, which is NQS. There are different domains for eligible professionals. It gets a little confusing, but it must include at least 1 CQM from 3 of the 6 National Quality Strategy domains. And as you can see here, 1 is patient and family engagement, then you have patient safety, care coordination, population, public health, efficient use of healthcare resources, clinical process, and effectiveness. So essentially, there's 9 measures that an eligible professional must meet. Out of those 9 measures, they must choose at least 3 that meet or must have 1 CQM that meets at least, that has 3 of these National Quality Strategy domains. And now we're going to have our next poll. Fallon, if you could please put that up.
Thanks, Carolina. For the next poll, I'm going to open this. We're just interested in what point of the process, of the attestation process that your organization is in. So I see a few people are starting to answer already. It looks like a lot of people so far that have answered are in MU2, part of the MU2 process. So I'll leave this open again for about 30 more seconds. But it looks like, yeah, we're mostly at the MU2 level. So I'll pass this back to you, Carolina.
Thanks, Fallon. And now Phil will actually be taking over the presentation and talk more about HL7 and certified EHR software.
All right. Thanks, Carolina. Again, my name is Phil Anderson. I've been with Galen for coming up on a year. My time here has mostly been spent building and supporting interfaces while I do other kind of custom SQL work. Previously, before working at Galen, I was with an EHR vendor where I was working as an interface project manager. Just one thing to note, I'm kind of battling the end of a cough, so if you hear me drop off for a few minutes, I apologize. That's probably me just taking a sip of water. So before we start getting into HL7, one thing that Carolina mentioned and that I want to go into a little bit more detail is, are you using an ONC certified EHR software or modular software? The reason why I ask is because if you're not using an ONC certified EHR or interface engine, you will not be able to attest for meaningful use 1 or 2. If you've already, since most of you have already gone to meaningful use stage 2, you should be fine here. Just one of the things I really want to point out, though, is if your interface engine is actually ONC certified. I worked with a client previously where they were using Allscripts and they were using the ConnectR interface engine for an outbound immunization interface. As we were going through the process of building the interface, their immunization registry had questions regarding what interfaces were being used. We found out that they were using an interface engine as kind of a hub and spoke model to direct all their traffic out of their disparate systems, and that particular interface engine was actually not certified by the ONC. So the client was still allowed to use that interface as kind of like a pass-through. They proved that, you know, it was secure and had, you know, limited access. But one of the things was that we had to prove that the interface was not extracting or modifying the information, that all that was being done through the certified ConnectR interface, and that interface was just being viewed as a pass-through. So one thing to note, if you are not using an ONC certified EHR or interface engine, we do provide conversion services. So if you need to move from one EHR platform to another or one interface engine to another, we do offer those sort of services. All right, so what is HL7? So HL7 is actually Health Level 7, and this is the group that has been tasked to provide the standards for interoperability within the healthcare space. They are basically the organization that has been and set of standards for healthcare. So what does HL7 kind of do for the industry? So it improves care delivery, it optimizes workflow, it reduces ambiguity, and it enhances knowledge transfer. So just quickly going over the different versions of HL7. So we're going to focus on HL7 version 2 and HL7 version 3. So HL7 version 2, or 2.x, because there's multiple versions of it. So some of the pros and cons to using this version. So the pro is it's widely used. So 95% of U.S. healthcare organizations currently use some sort of HL7 version 2 interface. It's international, so more than 35 countries use HL7 version 2. It is it's flexible, in some cases very flexible, and it's also backwards compatible. Some of the cons of using HL7 version 2, so because it is flexible, it's impossible to have a reliable conformance test. And also that since it's also flexible, that there's additional time it takes to analyze and plan interface implementations. So you can't just kind of work on one global spec. You actually have to work with a particular customer's, your vendor's spec to make sure that you're meeting their requirements. So here's just a sample HL7 V2 message. If anyone has kind of heard of HL7, they should be pretty familiar with what this messages look like. It's basically a pipe delimited message. So let me just go over kind of the different components of the HL7 version 2 message. Each line will begin with this 3-letter acronym. This is considered a segment. So this is the MSH segment, so this is the message header segment. The PID segment, so this will provide you with your patient information. PV1 segment, so this will provide some encounter information. ORC and OBR will provide some order details, and then OBX will provide some result details. Within each one of the pipes would be considered a field. So the field will actually hold the particular information, and each field is designated for a particular type of information. And then separated between the carets are actually components. In this particular case, you'll get, say, an ID in the PID 3.1, and then PID 3.5, you'll get kind of what that ID represents. So here it represents an MRN. Some of these components or some of these fields can actually have repeating components. So that's what the tilde here stands for. And ampersands will actually are for subcomponents. So, you know, you can get even more granular with your components. So HL7 version 3. So if you start looking into HL7 version 3, you might have come across a few terms or acronyms that have been kind of tossed around. So there's a CDA, a CCD, and RIM. And you might be thinking, well, how does this all kind of help me meet meaningful use? How does this all come together? So the best way to really look at all this is that each one of these is kind of builds the foundation of the next piece. So for HL7 version 3, you have RIM, which is basically the backbone of version 3. Then you have the version 3 standard. You have a CDA, and then a CCD comes out of a CDA. And I'll talk about these in more detail in the presentation. So first, let me just talk about HL7 version 3. So this is just based off of HL7 reference information model. HL7 version 3 will produce their messages and electronic documents expressed in an XML syntax. So this is totally different from that pipe delimited message format that we saw before. And HL7 version 3 is also designed for universal application. So you exchange the same messages across multiple applications. So RIM is the reference information model. So XML cannot be used alone for your standard. So RIM is basically the cornerstone of the V3 development. And what the HL7 organization did with RIM is they kind of took a top-down approach to the development of this V3 standard, where they decided to build more of the architecture around it, and then after that architecture, really start focusing in on more of the particular details and scenarios that could be had in the healthcare space. So RIM is kind of broken down into 6 core classes. So there's an act or action. So this is what was performed or requested. An act relationship. So this represents relationships between different actions. There's participation. So participation is who participated, say an author or a performer or an ordering provider. There's a role. So you could see as a role as like a patient and a provider. A role link, which represents the relationship between the individual roles, and an entity, which is the actual person or place. So the details of those entities. So the best way to really kind of understand RIM is to look at the kind of model that they've kind of created here. And what I could do is I can kind of walk you through it with different scenarios. So you could think of an action as saying like ordering a test, and then if you were to have, say, an order and then you actually had the result that came through, the act relationship would actually connect the two actions. There's right down in the light pink, these will be the details of the particular action. So if it was an order, it would give you the details of the order details. Participation, so you'll have the ordering provider or the patient subject. Now then you have the role where that ordering provider is a provider and that the patient is the patient subject is a patient, and some of the details associated with that. So for a patient in the role link would provide, MRN information, or if it was a provider, their MPI information. And then the entity, so who the actual patient is, and then who the actual provider is, and then some of their demographic information. So you can kind of see from this approach, it kind of takes an agnostic view of the healthcare space and describing kind of scenarios within the healthcare space. So you can also view it as baseball, where if you had a pitcher, a pitch and a hit, the action is you have a pitch and you have a hit. The act relationship will describe, will kind of link that pitch with the particular hit. The information down here will give you some facts on like the speed of the ball, what kind of ball was thrown, and a hit, where that ball was hit. The participation would be a hitter and a pitcher. The roles would be the actual players, and what teams they are on. The entities would be who the actual players are, and then their information. So that's another way to look at it. So you could see that this kind of why this is kind of a top-down approach and not like a bottom-up approach as was the case with the V2 development. So next is the CDA, or the Clinical Document Architecture. So the CDA specifies the structure and the semantics of the clinical document for the purpose of exchange between healthcare providers and patients. So the CDAs can include text, images, sounds, and other multimedia content. And some examples of the CDAs are your CCDs, which is the big one, a console note, diagnostic imaging report, or discharge summary. In the United States, really this is just the CCD. Most people are still probably receiving their consult notes and their diagnostic imaging reports, discharge summaries through HL7 version 2 MDM message. So with a CDA, there's actually six characteristics that define a CDA. So the first one is persistence. So a clinical document continues to exist in an unaltered state. There's stewardship. So a clinical document is maintained by an organization entrusted with its care. Authentication. A clinical document is an assemblage of information that is intended to be legally authenticated. Context establishes default context for its content. Wholeness, so the authentication applies to the whole and does not apply to portions of the document. And human readability, which basically means a clinical document is human readable. All right, one more other thing I just kind of want to mention is the CDC and the Public Health Information Network, or PHIN, and kind of the role that they play in meaningful use. So as we'll go over, a bunch of the meaningful use core and menu measures are public health measures. So PHIN was, excuse me. So PHIN basically worked with the CDC worked with the ONC to help develop and disseminate requirement standards for the public health measures. PHIN also helps monitor the information exchange capabilities of your state and local registries. They also develop methods to validate, test, and certify electronic messages. And one of those is the MQF, or the Message Quality Framework, which I'll show you later during my demonstration. So we'll just take a quick break and have Fallon do poll number 3.
Thank you, Phil. For this last poll, we're interested in which measures you're currently pursuing that you might require an interface. So there's syndromic surveillance, imaging results, lab results, or cancer reporting, or if you're not pursuing any of those currently. So if you wouldn't mind taking a few seconds, I will probably leave this up again for about 30 seconds. And it looks like so far we have some people looking at the electronic lab results to ambulatory providers. That's sort of in the lead, with imaging results close behind. So I'll leave this open for 30 more seconds, but I'll pass it back to you now, Phil.
All right, thanks, Fallon. All right, so now we're just going to start going over the different core menu measures. And first, I'm just going to start with version 3 and just discuss the different measures. Let me just get rid of that. Discuss the different measures that can be met or assisted using of HL7 version 3 interface. So the first one is actually clinical decision support. I just kind of starred this one. This is not an interface or an integration that you would have to actually worry about. This is something that your EHR vendor would have to have developed on their own. So basically, clinical decision support. So this is just the capability of your EHR to kind of take certain conditions for a patient and take that information and actually provide your providers with education, so information on, say, a particular care plan. So this is both a core measure for your eligible hospitals and professionals. And the HL7 version would just be V3, so it's not a CDA or a CCD, it's just a standard V3, and there's a separate implementation guide. And one of the neat things that they've done here is the implementation guide is for something called an info button. And what the info button does is if your EHR doesn't actually want to, take the time to actually develop those educations within their particular EHR, they can actually work with third-party vendors to help actually with this particular objective. And what they do is, if your particular patient presents with certain conditions, and based off the diagnosis codes and certain SNOMED codes that are listed for that patient, you can actually go into your EHR, click on a button. It will actually send out a version 3 HL7 message to the vendor that you're working with, and that vendor would then return back a URL that would give you that tailored education that your providers would need for the care plan for that particular patient. So it's something you don't need to worry about. But I think it's something worth noting. The next one's one of the big ones. So provide patients the ability to view online, download, and transmit information. And this is a core measure for both eligible hospitals and eligible professionals. So this means that you have to do it. So the big thing here is patient portals. That's kind of one of the big ways that organizations are helping meet this measure. And so the only way to really get a good summary to your patient portal for your patients to review is through the HL7 CDA CCD document. So one thing to note here is that with a lot of EHRs, you don't really have insight or into your CCD. Your CCD is basically, it doesn't work, say, with some of your, say, an orders interface where that particular HL7 message is kind of developed and designed within your interface engine. Your CCD is actually kind of built out of your EHR, and your EHR is really the one that's in control of kind of getting that information out there. You might use your interface engine as a way of kind of transporting that to a particular vendor, but the interface engine is not actually creating your CCD. So sometimes you run into issues with this. So the CDA, the CCD, if you were to look on the HL7 website and look at the CCD spec, what you'll notice is that they're obviously optional and required fields, and your EHR vendor will most likely would have just developed their CCD based off just the required fields. But unfortunately, a lot of vendors will require some additional information. So within a standard CCD, you'll get a problem list, medication, results, and demographics. And there were actually particular cases where that I worked with a client where they asked us to help scope out where, they're receiving the results, but they're not getting their results annotations. So if a provider wanted to comment on a particular result, they didn't have the ability to do that, or that information was not being sent out to their in their CCD. So we actually had to think of different solutions on how can we get that annotation out of the EHR and to the particular vendor. Excuse me, hold on one second. Okay, so one thing that I also noted here is V2. So for this particular objective, there's actually a measure that actually 5% of your patients actually need to go online and actually view the records. So it's one thing to actually be able to provide them the ability to do it, but there's another to actually have active participation with your patients. So some of the integrations that we've done for between EHRs and portal vendors is something called online indicator. And what that is the the vendor will actually send across an ADT message and indicate in that ADT message if that patient is actually active in the patient portal. So that what that then does is what we do is we take that HL7 message, and with the integration we actually flag that patient within the patient's chart and create an icon. So if a provider or their clinical staff opens up a chart for a particular patient in front of them and they see that this icon has not been flagged, they can actually talk with their patient about the patient portal and give them additional education. Next is to provide summary of care record. So similar to the previous objective, but this is providing the summary of care record to, say, a referring provider. So this is a core measure for both your eligible hospitals and eligible providers. And again, you're using the CDA CCD. So one thing also to note about the CA standard is that it actually does not define a standard for transferring the documents. So one of the big ways of transferring these types of documents is through direct messaging. So if you have that set up, you would use direct messaging to send your CDA or CCD across to, say, a referring or a consulting provider. All right, next objective is cancer registry reporting. So this is just a menu measure for your eligible providers. It's not a requirement for your eligible hospitals. And this uses an HL7 version, a CDA. It's not a CCD. There's actually specific implementation guides for your cancer registry. There's a standard one provided by the HL7 organization. But if you're reporting to a particular registry, they probably have their own spec themselves, where they might require additional information that would be deemed optional in, say, the HL7 organization's spec. All right, so next is the V2 measures. So this is the big one. These are the ones most widely used. So just kind of going down the line. So again, these are the HL7 V2 messages. In some cases are required to help meet these messages, measures or objectives, but in some cases it could just be used to kind of assist. It's kind of a plus. So the first one for demographics. So this is both a core measure for eligible hospitals and eligible providers. So this is capturing, the patient's sex, date of birth. So typically you could just kind of go in there, and I think you have to at least record 50 or 55% of your patients this information in their EHR. So what you could do with this interface is, if you're recording this information in your practice management system, you can actually set up an ADT interface from your practice management system to your EHR and help fill out most of those requirements under that demographics objective. Most people do. It's basically the way that you get your patients into your chart, but you'll want to make sure that you're actually carrying over that the necessary information. So if you're actually in your practice management system capturing, race and ethnicity, if you are capturing that, you want to make sure that your ADT messages are actually carrying that information over to your EHR, so your staff doesn't have to do that double entry and fill it out in the chart. Next is clinical lab test results. So this is a core measure for both, and this uses an HL7 ORU message. So this is kind of a big one. Most people do have at least an inbound lab results interface. So what they're really looking for are numerical results, so kind of discrete results, and also results that have a positive and a negative value. If you're just kind of receiving pathology reports, just kind of like detailed transcribed reports for your labs, that actually does not count on this measure. So they're really just kind of looking for those discrete, numerical results here. Next one is reportable laboratory results. So similar to clinical lab results, but here is actually more of an outbound interface. So this is for eligible hospitals, and again, it uses an ORU message. So what they do here is, if you're an eligible hospital, either your lab will actually send that information out to a public health registry. So this is kind of one of those kind of one of those public health measures that is monitored by PHIN. So either your lab system, so your LIS system, could be used to send that information out. It's only based off certain tests and certain conditions, or in some cases you can from the EHR side, you can kind of bundle the messages, the ORU messages that you've already received, and batch them out to your public health registry for those particular conditions that they're looking for. Excuse me. All right, next objective is immunization interface information. So this is both a core measure for your eligible hospital, eligible provider. And this uses a VXU message for capturing your vaccine information. Excuse me. Again, this is another one of the public health measures that is out there. One thing to note here, so in Meaningful Use Stage 1, there was I believe it was a core measure or menu measure that what you had to do is you had to at least send one test message to your immunization registry. So now you actually have to have ongoing submission. But one of the big differences was in Stage 1, they allowed HL7 version 2.3.1 or 2.5.1. So in Meaningful Use Stage 2, they explicitly state that it's HL7 version 2.5.1, but you can actually kind of get grandfathered into this. So if you're still sending HL7 2.3.1 to your immunization registry, and they are accepting 2.3.1, you're fine. Once they switch over to 2.5.1, you will be required to switch over to 2.5.1. Next objective is syndromic surveillance. So this is actually a core measure by your eligible hospital and a menu measure by your eligible providers. And this is actually an outbound ADT message. So they decided to use an ADT message instead of an ORU because it was actually provided more information about in kind of emergency and critical care situations. So the ADT was a better message format for this measure. And basically, this is, again, another public health measure that the CDC uses to kind of track kind of different outbreaks of different syndromes. Next is the imaging result. This is a menu measure for both eligible hospitals and eligible providers. And like Fallon mentioned in the poll, it seems like a bunch of you are kind of actually looking to actually meet this menu measure. So what you have to do in this one is, so you can receive your imaging transcription reports via an HL7 message, typically in an ORU or an MDM message. But now what you need to do is you need to provide access to that particular image for that particular case. So the best way to do this, or the most common way that people have been doing this, is through kind of an image link. So your PACS vendor will send the HL7 message and actually include a hyperlink within that message. That hyperlink is then consumed by your EHR, and then based off of certain configurations, you can create a button within your EHR or a link within your EHR. And when you click on that, it will actually direct you directly to the image associated with the study with the text that's provided in your HL7 message. This can kind of be done multiple different ways. Currently, right now, I'm working on an interface, a PACS image link interface, where the image is actually sent in an ORU message first, indicating that the image is now available to view. That order will actually stay in progress, but if they click the order, they can actually go in and click the image. The image link button, it will open up so the provider can see the message, see the image, and then once that report has been reviewed and the transcription of that of the details of the report have been sent back to the AHR, it will update that order as if it was resulted. We'll provide the kind of the dictated report of that message and still maintain that image link, so that link would still accompany the report that was sent in the latter message. Next is secure messaging. So this is secure messaging between a patient and provider, and this is a core measure for your eligible professionals. So what happens here is you can use an MDM message. So we've worked with numerous patient portal vendors, and what they do here is they use an MDM message to actually send across a a copy of a conversation between a patient and provider. So you might log into your patient portal so a patient might message their provider. The provider will go into their patient portal, and they'll see the message from the patient. They'll respond back to that patient. But unfortunately, if you have that conversation with the portal, that record just stays within the portal, and some of that information can actually be relevant clinical information. So what portal vendors typically do is they'll send an MDM message, so a standard document interface, that will contain the actual correspondence of that conversation. So if you're going back and forth between your patient and your provider, and that's relevant clinical information, what will happen is that MDM message will come across in the interface, come to your EHR and create a document within your patient's chart, and then you can actually view that conversation as a clinical document within your EHR. And that way you have that on file within the patient's record. So it's very important. Last objective is the electronic lab results to ambulatory providers. So again, this is another big one that was mentioned in the poll. And this is a menu measure for your eligible hospitals. So here, this would be an ORU and an ORM HL7 message. So ORU is for your results and your ORM is for your orders. So what CMS is really looking, and what will only count on this measure, are electronic orders and electronic results. And those results actually need to tie back to your orders. So that's one of the big things is to make sure that when you actually have your orders interface, you have your results interface, that the right IDs are being sent across and returned, that you can actually tie your result to your order. What's the point of having an electronic orders interface if your results are not tying to your orders? So this is a big one here, and again, you'll need to set up with your ambulatory providers an orders interface to your hospital lab, and then a results interface to your different ambulatory providers systems. All right, so next I'm just going to do a kind of a quick demo of an outbound immunization interface. There's not really a whole lot that I can show here. It's just I'm just going to show you kind of a sample build that I did for a client and how we kind of used our knowledge of the EHR and kind of what was needed to make sure we get the necessary information across to that registry. So let me just log in here real quick. All right, so in this particular case, it was an interface using the ConnectR interface engine. The client was a Allscripts TouchWorks EHR client. So for this particular example, we did an outbound immunization interface right here. And here's the message that we were able to create. So if we break this down, there's an MSH segment, a PID segment, an ORC segment, and then two segments that are really crucial for your immunization, so an RXA segment. So this actually includes the information around the actual immunization that was given. Some of the big ones are the CVX codes. So this is an HL7 standard right here. So this is a special code that your EHR vendor must have tied to your to the vaccines that you would be administering to your patients. This will also give you information such as the administering provider, dosage information, the amount, what lot number was given, and the manufacturer information. Since this is our test information, we actually don't have this information in here, but if we did, again, kind of like the CVX codes, these are standard codes for the different vaccine manufacturers out there. Next is an RXR segment, so this will indicate the route and the site of the immunization. So here we did intramuscular and in the left buttock. And then the OBX field will actually provide additional clinical information to that registry. So why this is a good information is that for this particular information, you needed to provide these vaccination eligibility codes. So for VFC, so vaccines for children, if you're receiving certain vaccines from your state, that state might or most likely will require you to send back this vaccine eligibility information. So this is some additional clinical information that is captured within your EHR. So one thing we noticed, or I noticed that when I was doing this build, is that this information did not actually come across in the standard extracts for this particular interface. So if you're familiar with, say, like an orders interface within ConnectR, there's actually an extract additional information. And we noticed that that wasn't actually getting the information we needed. So there's kind of two approaches to do this. The one that I'm going to show you right now wasn't actually what we implemented. I'll show you what I implemented after this. But what we did here was we actually created a custom extract within the EHR. And this was able to make to capture that information. The information is basically given to us via string. And kind of delimited by, carets and pipes to help kind of break up the information. So you have to kind of know how that's broken up to be able to actually then get that to file into your HL7 message or file in the necessary information. The way that I actually went about doing this was creating a script. And let me just go back to that message, I just got to grab some information. So because my client actually, or the registry didn't actually need all this information, it didn't actually make sense to go in and create these custom extracts in their system. So what we did was we figured since we just need that vaccine eligibility code, we just designed a script for that instead. So I just need to grab this number right here. So if we look here, this was a script. So it was for the Alert Immunization Information System up in Oregon. And if I were to test this ID against it, you'll see that it's providing me the information I have right here. So my script will extract the information that I need, and I can then use that to help pull that information into my HL7 message, which you will see right here in the OBX field. And this was actually designed using the additional information extract here, but similar way. It was a similar way of how I was able to get that into the HL7 message using the script function instead. So one other thing to note to show you, if I could just exit out here, is I mentioned before FIN and the MQF, the Message Quality Framework. So one thing to remember is that the CDC actually designed a spec for the immunization registries that is a little bit more strict than, say, the spec that would be provided to you by your particular immunization registry. So they can kind of tone it down a little bit because they might not require all the information that the CDC actually says that it will require. So what we could do here, so what you could do is if you haven't started engaging, or if you engaged your immunization registry, but they're not ready to actually work with you yet, you can actually begin validation here. It's not a robust tool. It's not going to give you a whole lot of information, but it's a good start. It's a good start to kind of get ahead on your implementation. So here is just a copy of that HL7 message that I was showing you in ConnectR before. Here we go. And if I submit it, so it's nice that it's kind of a neat tool. So one of the things they could do is they can kind of parse the message out for you. So if you want to kind of look at the PID segment and look at all the different fields that are in here, we'll show you what you're filling in, kind of if you're missing any information in any of these other fields. It's also a good way to kind of educate you on HL7 if you're not really sure kind of what all the different components and subcomponents mean. That will kind of break down the entire PID segment message standard. Same thing with the OBX. And then next is the structural validation reports. So again, this is not really looking for content, but just that that you have information in here. So you can see here that I am missing some information. It wasn't a direct copy of the integration that I did with the client, just kind of another quick rebuild that I did. So you could see that I'm missing some information, and you kind of take this and you say, okay, well, I'm missing my RXA, field 7 information. I'm going to go ahead and look at my message. And if I went back into ConnectR and I pulled this up and I see, oh, okay, well, it looks like I'm just pulling in, RX, doesn't look like I'm actually pulling in the dose units. This is actually a good example of something that the CDC requires, but your immunization registry might not require, or can kind of help get around. This particular EHR we weren't able to really get the dose units out of the EHR, so we kind of worked with the registry to figure out a workaround by not being able to provide this particular bit of information. So again, if you were kind of building something and you notice, hey, I'm not really able to get that information, wait until, just kind of leave it at that. You've kind of done your best, and then when you get to when you start engaging your immunization registry or any of your other registries, you could say, hey, okay, here's my message. If they comment on it, be like, hey, you know what, I haven't been able to get it. What do you do in these particular situations? And you can work with the registry to see what they do in those scenarios. Oh, and then one other thing just to point out is, so here's that certified health IT products list. See if your EHR or modular EHR, or so an interface engine would be considered a modular EHR in this product list. So if I wanted to go and check if my Rhapsody interface engine is actually ONC certified, I can go in here, look up the product. Okay, I'm using ambulatory. I'm using version 5.5 of the Rhapsody interface integration engine, and because it's on this list, you'll see that they're certified. These are the different testing requirements that were designed by NIST, so the National Institute for Standards and Testing. So your EHR actually has to meet all these measures, or I think most of them. I think some of them don't need to meet the calculate and submit clinical quality measures. Don't take my word for it, but I have seen certain EHRs that didn't have this one checked. But for this particular interface engine, it's saying that, okay, we're certified to submit to immunization registries and public health surveillance. We have access control, emergency access, automatic log-off, integrity, and authentication. So based off of these particular testing measures, ONC was able to, they were able to get ONC certified. Some interface engines will not actually have all these checked off, so you want to make sure as also that, some of them will just have this information below listed as part of their test plan. It may be not submission to immunization registries. So if you notice that your interface engine is ONC certified, but if you're sending to a public health registry and you notice that, hey, submission to immunization registries is not actually listed, you might want to talk to that public health registry to still make sure that that interface engine can still help you meet meaningful use. All right, so to conclude, one of the things is, let's just break down basically how many HL7 interfaces, or how many menu and core measures actually are either met or assisted by an HL7 interface. So for eligible provider professionals, so 41% of your core measures and 66% of your menu measures could use or need an HL7 interface to help meet those measures. Eligible hospitals, so 50% of your core and 33% of your menu. And one thing to note is that version 2 accounts for 65% of those interfaces that would have to be created for your core and your menu measures. And then also, kind of going back to what Carolina was saying with the meaningful use portion, so even though there's no more incentive payouts for Medicare, but that still means that you still have to prove meaningful use to avoid those penalties. So obviously, if you're a very large organization, those 1, 2, 3, 4, 5% Medicare payment penalties are going to really hurt if you don't attest for meaningful use. So at the end of this presentation, we'll actually provide you some copy of these slides, and so here are just some of the links that we used for this presentation that can help. So this CMS website that will go over the EHR incentive programs, meaningful use, healthcare IT. So this will give you kind of more information on the meaningful use definitions and objectives. The CDC's EHR meaningful use page. The ONC, so this is that products list page, and then also HL7.org if you want to get yourself familiar with the different HL7 versions. All right, so I'm going to open this back up to some questions. So throughout the presentation, we did have a Q&A. So Fallon, I am going to send this back to you.
I think we received a couple questions. And again, if you're still on, feel free to open the WebEx application and enter any questions you might have remaining, and we'll try and get those answered before we close out the WebEx. I got a question asking what are the differences between the different versions of HL7 version 2. So there's 2.3, 2.3.1, 2.4, 2.5. While significant changes have been made since the first iteration of HL7 version 2, HL7 version 2.5, which is the latest version of HL7 version 2, is more consistent, and it supports more functionality than the previous version 2 versions. Sorry, a lot of versions there, but the changes in comparison, though, to 2.4 are, however, relatively small. But in between 2.2, 2.3, 2.5, we see that more fields are becoming required and more granular. So like MSH4 is now required. ORC segments are new. RXA message types are also new in version 5. And then version 3, which Phil talked about, is like even more strict in efforts to have all organizations follow a common standard with as much detail included as possible, so that there is a standard and it's not so easy to change back and forth between one or another. So I think there's another question, if you'd like to answer that one, about the ONC certification.
Yep. Someone did ask if what makes an interface engine ONC certified. So the ONC actually uses kind of designated groups. So one of them is the drumming group. If I can pull up the website again, you wouldn't have insight into this. But they use different organizations to kind of help them with their testing for different softwares. And those organizations will work with that National Institute for Standards and Testing test list that I showed before, and they'll kind of work with them to actually get them to test on those particular measures. And if they actually pass those a certain list of those measures deemed appropriate by those testing authorities, they will become a certified ONC interface engine that is ONC certified. The actual details of how many of those actually need to be completed is still unclear to me. But if it's on this list, you can be assured that that interface engine is certified. If not, you could reach out to your interface vendor and ask them about it as well.
I believe those are the only questions that we received. Thank you all for joining this webcast. If there's any questions that you might have, please feel free to go to galenhealthcare.com and contact us if anything comes up, and we'd be happy to help you try and create some of these HL7 interfaces to meet meaningful use. And we do have meaningful use experts that work with us that help EPs and hospitals achieve meaningful use and do the attestation process. So thank you all. I hope you have a great day. Bye.